Well, hi, everybody. Welcome to Friday conference. We'll get started. Okay, let's pull up my slides. Okay, great. So, just in follow-up to last week, I will start off by saying that we have an upcoming conference that everyone should tune into when Chloe Theo is going to join us to sort out all the things that we should know about hepatitis B and vaccination practices and nuke-sparing regimens and these really critical questions as those regimens become more and more common in our general practice, and to just make sure that we're on top of all of those, and also with the initiative that Joyce and Randy have been leading to make sure that we have good data and good vaccination updates for all of the people who were switching off of hepatitis B active drugs. So basically, more experts, commentators than were available last week, meaning only me. So please stay tuned for that. It will be November 14th. And will be announced in the usual format. And then other upcoming conferences. So please do send any cases that you'd like to have discussed in our conference. We do have some case discussion slots coming up, including one for next week. And please send anything along, and then Joyce will be leading a case discussion also in later October. Okay, great. So now I thought I'd start with some of the things that, actually, I should just pause there. Any announcements or updates that anybody has? Just say, I'll leave a appropriate Zoom pause. Okay, great. So today I thought I'm just going to go over some of the clinically interesting studies from IAS 2025, which I was able to virtually, but not personally in real life attend. So I'm going to start off with updates from Purpose 1. So Purpose 1, as many people will remember, is part of the suite of trials that has led to the approval of lenacapavir as used for pre-exposure prophylaxis in a twice-yearly format. And so Purpose 1 had a couple of features that were really pretty groundbreaking in the trial design. One of which was that they used the background incidence at the time of enrollment as a control group, which was really screening, sorry, not enrollment, as a placebo control group to control against background rates of HIV incidence. And this allows us to conduct PrEP trials with use of active controls and still be able to quantify whether or not the PrEP works over untreated incidents. So just to say that again, when people were enrolled in Purpose at screening, they detected a certain number of individuals who were already HIV seropositive. They used sort of detuned ELISA's kind of approaches to determine how many of those people had been infected, had acquired HIV rather, in the about 3 months prior to the start of the trial. And they used that to get an incidence rate of what would happen if you did nothing. And so then in Purpose, they randomized people to either receive lenacapavir or to receive FTAF or to receive FTDF. And FTAF, as people will probably recall, has not been approved by the FDA for use in individuals whose risk of HIV acquisition is vaginal sex, because it has not been shown to have efficacy in women specifically for the prevention of HIV. So this was an opportunity for FTAF to also show itself as an effective PrEP agent. And Purpose 1 enrolled cisgender women, and specifically to address the pre-exposure prophylaxis in that population. So the questions at this particular presentation, which was given by Linda Gale Becker at IAS in 2025, was, is lenacapavir twice yearly for PrEP efficacious and safe during pregnancy and lactation? Other questions were, are the blood levels of lenacapavir during pregnancy and postpartum different compared to non-pregnant women? So efficacy and then PK secondarily. And then, is lenacapavir present in breastfed infants? So a couple of key questions. So Purpose 1 was the first time that women who were becoming pregnant were included in a phase 3 PrEP trial. And it's sort of a shift in the ethical approach to this is, instead of protecting women from research, but protecting women and their infants through research, is sort of the framing that this has been given. You know, as a first off stand, like key feature prior to moving forward, there were preclinical studies that did not indicate any harmful effects on fertility, pregnancy, fetal development, or postnatal development. So there was already some basis for suggesting safety. I will say that, you know, to be perfectly frank, there's very little correlation between preclinical studies, which involve mostly looking at the mutation induction rate in a cell line or in animal models, and eventual identification of teratogenicity. So it's good to do. It doesn't actually give us the information that we need. But in the end, as we've all observed in various cases, like you really have to actually see what the drug does in order to know what the drug does, unfortunately. So this is a new model of approaching this idea of conception and how to think about it and how to engage people. And so just to mention also, they engaged both investigators, community members, ethics committees, both sides, maternal and fetal and pediatric experts, and pregnant and lactating people in the design of the study. And then everyone was offered contraception at all visits, and but it was not required. And so this is a major departure from a lot of clinical trials, especially of this phase, for which typically the requirement is documentation of 2 active forms of contraception. I remember, you know, people would say they used spermicide and also condoms or something of the like. But that used to be pretty much a typical requirement for this phase of trials. And in terms of inclusion, so people who became pregnant could remain on study after a reconsenting process. So they weren't just rolled over, nobody ever talked to them again. But if they were included, then they were reconsented at the time of diagnosis with pregnancy. And they did have an option to include fathers in the pair in the consenting process. And I'll just call that out briefly, that in the question and answer period, one of the questions was about what the study team would do if there was a discordance in agreement for consent between the 2 parents. And specifically, this has not happened in their trial. They did not observe a case where it was reported to the study investigators from a study site that there was a discordance in consent, but that is something for to think about as we draw these models. Their model was explicitly health of the pregnant woman first, and the pregnant woman was the one who was given the choice of including a partner in a consenting process. And then they included, you know, implemented all the recommendations from the WHO and IMPACT toolkit on inclusion of pregnant and lactating people in the study. So any questions on any of that? I'll just go ahead. So this is the design of the trial. Just again, many of you are probably familiar, but just so we're all at the same place, there's the initial loading dose of, cisgender women were screened, not on PrEP, actively, no HIV testing in the past 3 months, and a negative pregnancy test at the time of enrollment. That was a requirement at enrollment. If you're tested negative and then you were otherwise eligible, then you proceeded into randomization. If you were HIV positive, then they used a recency assay to estimate background incidence, which again provided our sort of placebo control for the trial. And so the 3 active arms were about 2,000 women each in LEN subcutaneous every 26 weeks and in FTAF oral daily. And then FTDF was the other active control. So both FTAF and Len are considered investigational because this is a risk factor of vaginal sex as a risk for acquisition. And they had a pre-specified primary analysis of Len versus background and FTAF versus background, and then some additional analyses that compared within regimens. And then the top line results from this have already been reported, but dramatically efficacious with no incident infections in the lenacapavir. I'm just going to skip ahead to this just to show this. So the background incidence was about 2.41 per 100 person years. In the lenacapavir arm, there were 0 infections. In the FTAF arm, there were 39 infections. In the F2DF arm, there were 16 infections. And there were 5 incident pregnancies in participants, 5 incident HIV pregnancies in, 5 incident HIV infections in participants with pregnancies. So there were a substantial amount of people who, as we say, fell pregnant during the study. So I will also just point out that this did not show efficacy for either FTDF or FTAF as a preventative intervention in cisgender women, which is consistent with prior studies. The mechanism for this has been in prior studies been shown to be lack of adherence to the oral PrEP regimen. I don't actually know off the top of my head if they confirmed that that was the reason for lack of efficacy here, but it will not lead to a new labeling of FTAF. That is clear. So that's the trial. Now, what we're talking about here about pregnancy and infant sub-study. And so this sub-study included all people who became pregnant while receiving lenacapavir and their infants if the individual consented at that reconsent step. And their objective here was to look at maternal concentrations during pregnancy and postpartum visits, assess to see whether those are similar to those who are non-pregnant, and then to look also in breast milk and in infant plasma. But they did not schedule additional outside visits. So they just did the regular sampling that would have been planned for the trial. So as you can see here, they've got 4 examples of pregnancies, and you can see when the pregnancy occurred and then when the sampling occurred would matter. So this person here, example number 1, fell pregnant, very early on. And so they would have sampling throughout all trimesters. Someone who fell pregnant at, in between the week 13 and week 26 visits will also have sampling. But again, which trimester those visits fall in is random. The sampling was not linked to trimester of pregnancy. It was just applying the same rubric that was being used for all people, and whatever trimester you happened to be in was the one that you got sampled. So who were the people who became pregnant and how many? So in the lenacapavir arm of 2,140 people, there were 184 pregnancies. In the FTAF arm, we had 208. In the FTDF arm, there were 95. And as far as predictors that varied across the cohorts, like was there anything different about those who became pregnant as compared to those who did not? There was a lower level of educational attainment in those who became pregnant during the study. And there was also a higher rate of transactional sexual activity where it's being used for financial or material support. So those were just 2 of the characteristics. And so there were a total of 487 participants with a total of 509 pregnancies. Some people did become pregnant more than once. And the other baseline demographic characteristics were similar. So this we've already talked about. So here are the pregnancy outcomes. So this is like asking that first top line question of efficacy. Is it as efficacious? And here pregnancy outcomes were similar to those expected in the general population. Apologies, this is not about efficacy. This is about teratogenicity or birth outcomes. So here comparing across arms to FTAF and FTDF, again, we don't have a placebo control in this group, but we do have like lots of other studies where we know what the background incidence of a lot of these birth outcomes is. In this population, there was no difference in birth outcomes by treatment arm. So lenacapavir did not have an increased risk of stillbirth, induced abortion, or spontaneous miscarriage. They looked at both chemical pregnancies and clinically diagnosed pregnancies in this analysis, and there was nothing that varied across. They saw the expected spontaneous miscarriage rate, 10 to 20% of clinically recognized pregnancies and approximately 30% of biochemically detected pregnancies. And the incidence of congenital anomalies was also within that, which was expected for the background rate, although keep in mind that you have to have a lot of pregnancy outcome events in order to observe an increased incidence of an adverse birth outcome. So as far as safety and tolerability, there was excellent across all arms. Only one discontinuation due to an adverse event. This was in the lenacapavir group, and the lenacapavir adverse events were predominantly injection site reactions, as has been the case for almost all of the studies involving lenacapavir. And then in terms of their questions about pregnancy PK, was this similar? Was the exposure similar? So across pregnancy and postpartum, so we have week 26, week 52, and week 78 here. I think just looking at it with the eyeball, you can see that these little boxes are roughly the same. And so what are these boxes? So the red box all the way to the left for each of these categories is those who did not become pregnant. The gray box is during the non-pregnant period. So that's that individual's exposures during a non-pregnant period. And then orange is first trimester, that light blue is second trimester, purple is third trimester, and green is postpartum. And as you can see, that there's variability of sampling across this, but there really isn't. It does not look like anything is going on in terms of the trough levels of lenacapavir. So they also looked both at different sites of administration, and the lenacapavir trough PK was similar, whether the injections were administered in the thigh or in the abdomen. So then their next question was lenacapavir exposure via breast milk. So here they looked at breast milk to mother plasma ratio in 102 matched pairs where they had both the breast milk sample and the mother's plasma from the same time point. And the median was about 0.52 ratio, so it's substantially lower in the breast milk, but it is definitely present. And then they looked at infant plasma to mother ratio in 98 matched pairs, and the median of this was 0.02. So again, much, much lower levels of exposure, but there is still some exposure. I will say that, this is a great way of looking at it, but I think one thing to think about is that doesn't tell us what the actual level of exposure is in the infant. It just tells us the ratio of exposure to the mother. It still seems extremely low, but that's just a little tiny point of like, well, I just wonder how much it actually is. So their conclusion from this was that lenacapavir is present in breast milk, but with very low concentrations in breastfed infants. And then also, I should just go back to this because when I sort of jumped ahead and then went back, I kind of missed this point, but there were no incident HIV infections in participants on lenacapavir who became pregnant. So the efficacy was the same, which we knew because there were no infections in anyone on lenacapavir. There were 4 in the FTAF group and 1 out of the 95 in FTDF. So and not a significant difference across those. But again, we also know that likely the fact that there was acquisition in those groups suggests that there was probably incomplete adherence in those groups. So that just something to keep in mind. And then there were no cases of vertical transmission of HIV during the trial. So just to summarize what this all said about lenacapavir, so is twice yearly lenacapavir efficacious and safe during pregnancy and lactation? It appears that the answer is yes. Are blood levels different? No, there was no detection of differences in blood levels during pregnant or the postpartum visit that they looked at as compared to their own control of a non-pregnant period or other individuals who were not pregnant at any point during the trial. And is lenacapavir present in breastfed infants? So yes, but at a very low plasma level, and it does appear that it is coming through the breast milk. So what are the conclusions we can draw from this? So no dose adjustment is necessary for len for PrEP during pregnancy or postpartum. 95% of eligible participants continued on this during the open label extension, again, underlying that this, for people who opt for it for pre-exposure prophylaxis, is a highly, people like it and want to continue. And lenacapavir for PrEP is now supported in pregnancy in the FDA labeling. So in the CDC MMWR that came out just on September 18th, discussing guidelines for use of lenacapavir for PrEP, they specifically say that len PrEP may be used in pregnant women or continued in women who become pregnant while receiving injections, considering the women's risk for HIV without PrEP and after provider and client shared decision-making. So that's a pretty strong statement. And like, it's really just, I just have to say, like, fantastic. I mean, the average lag time for good data about antiretrovirals in the setting of pregnancy was classically 10 years from approval to when there was adequate data. So this is just really a groundbreaking approach to including this population of people who are globally at extremely high risk, but also locally, and to establish some, boundaries about safety and parameters about which we can say that we think this does work or not. Before we move off of pregnancy, I'll just briefly mention there was one abstract on cabotegravir in pregnancy. So this is data from the Antiretroviral Pregnancy Registry, which is a voluntary reporting, collecting registry that really has been critical to our understanding of the use of antiretrovirals in the real world, and also to building up data about potential adverse effects from exposure without having RCTs to prove it. So keep in mind the threshold for identifying a twofold increase in birth defects is 200 first trimester exposures, because the baseline prevalence of a birth defect is about 3% in the general population. So in order to see a twofold increase in that, you have to look at 200 exposures. And again, also keeping in mind that first trimester exposure is really the critical developmental period for congenital anomalies. And the other thing we should consider is that cabotegravir may be stopped during pregnancy, like, or at the diagnosis of pregnancy, but because of the tail of exposure, that you can't really change off of it in the same way that you can stop an oral medication and have a washout. So one other thing to consider as we sort of gather more data around this. So they looked at 42 long-acting cabotegravir exposures. There were 32 that had used cabotegravir as antiretroviral therapy and 10 in pre-exposure prophylaxis, and there were 35 live births. And there was one congenital anomaly, which was a congenital ptosis or eyelid droop. So this added to some data from HPTN, which was 084, a pre-exposure prophylaxis study of cabotegravir. But we still need some pharmacokinetic and safety data to add to this. And I think from an antiretroviral therapy in pregnancy safety standpoint, the PK data about rilpivirine exposure is probably another area where we really would want some data, as from the oral formulations, which are limited by the GI absorption questions, that is an antiretroviral that has not achieved the levels that we would want during pregnancy. I think also, like, another question in terms of as we think about optimal therapeutics is rilpivirine does have a low but present failure rate, even with on-time injections, and how we counsel people about that for during pregnancy will, I think, be highly context specific. If it's an individual who's been unable to achieve viral suppression with oral therapy, then it's a no-brainer. If it's an individual who prefers injections, but was actually very well suppressed on oral regimens in the past, then I think it's a slightly different conversation, but one that we should be able to manage. So I see some chats, sorry. So Mickey's asking a question about 2 incident infections in Purpose 1. I believe that's in Purpose 2, which included the adolescents. Is that what the study you're referencing? And there were, go ahead.
Sorry, I got confused. I thought it was Purpose 1.
I think it's Purpose 2. I would have to check. I don't know. Ethel, I see Ethel here. I feel like she knows everything on lenacapavir, but I believe it was in Purpose 2 that there were 2 incident infections. And
Agreed.
okay. And my understanding of that is that both of those individuals showed capsid mutations. What was not clear to me was whether those were believed to have been selected or present and pre-existing.
So I think the 2 infections I'm talking about, in Purpose 1 that I thought I read, one had capsid mutation. The second one, they could not because the viral load was too low.
Okay. Okay. I think this question came up, like, Mickey, you're right on target. It came up in the question and answer period about the whole, like, there was a whole session on Purpose. and being purposeful. And that question came up a couple of times because people are very interested as to why those two didn't work. I was poking around at this before this talk, but it didn't get deep enough in it to answer this definitively. But there are a couple of studies looking at some of these. It's hard to call them resistance mutations because to really call something a resistance mutation, you have to demonstrate that it means that the drug is inactive. But resistance-associated substitutions, as I think we say it in clear language for about things like hepatitis C. But there are some that do occur in the background in individuals without prior exposure, but I think they are extremely rare. So what I would say is that this was the source of several questions in the session, and the answer was the one I've given, which is that there was some capsid resistance mutation detected, but no further details about why they thought that were offered at the time. So that is something I think to stay tuned to understand as we get more data. And I don't know if anyone on the call has more information about that than me. I'm not a purpose investigator. No? Okay. But any questions or thoughts about this? I mean, I think realistically, like if you're going to offer a cisgender woman pre-exposure prophylaxis, your strongest data, who's of reproductive potential, and is at risk for HIV, which suggests that they're likely having condomless sex, that I think lenacapavir has really got the best data to support its use specifically in that population. I don't know if anybody wants to disagree with me on that. Okay. I don't know if insurance will agree with me, but great. So I'll move on to the next thing I was going to talk about, unless anybody has any thoughts or feelings. So then there was a really nice, also by Linda Gale Becker, who is like just amazing as far as I can tell. A very nice presentation on some common questions for the use of lenacapavir. How do we think about using this when other things happen? So for example, just to level set here. So the oral lead-in is 2 pills on day 1 and 2 pills on day 2, along with 2 injections on day 1. So, and they emphasize this again and again, that you cannot take all 4 pills on day 1. Does not work. Don't do that. 2 pills day 1, 2 pills unobserved day 2, and an injection on day 1. That's the way you load and get to therapeutic levels. Lenacapavir is a substrate of cytochrome P453A, CYP3A, and a moderate inhibitor, and it has a very long half-life that can, impact drug-drug interactions for a long time. So the questions that they were addressing in this particular presentation were what to do if lenacapavir injections are delayed, and what to do if you use rifamycins for tuberculosis, and what about other common medications that might be of interest to our population. So specifically picking 2 phosphodiesterase inhibitors, which are erectile dysfunction drugs, and also used for things, it can be used by people who engage in chemsex, so frequent use in people at high risk, and statins, which are, as we know, basically being put in the water and with like high rates of indicated use in people living with HIV. So this part of it, so this is the time to protection, and this was just a point that Linda Gale made very clearly. So if you do the oral 2-day load, you get to protection in 2 days. So that's what's shown by this curve here on the left. So taken as indicated, 2 pills on day 1, 2 injections day 1, 2 pills on day 2, you get this nice peak and you're above the IQ40 that you want to, IQ4 that you want to be above, and you're protected in 2 days. And what's shown over here is the PK curve for people who do not take the oral load. And so those people get the subcutaneous injection, and it takes them 28 days to achieve full protective levels of lenacapavir. So any infection or any exposure during that time puts you at high risk of acquisition and also development of resistance because you do have drugs present. So this is the thing to emphasize to people that those 2 pills on day 2 are really important. And I think also this was, one of the challenges that came up in the question and answer period on this particular presentation, also how to implement this, like what do you tell patients, how do you best follow up to make sure that they're taking the medications that they need to take, et cetera. But it is pretty amazing to see 2 days and you're protected. That's like really wonderful. So question number 1, what do you do for delayed return for injection? So somebody says, oh, my job changed. I no longer will be able to come to the clinic during clinic hours. So that's the scenario that I think is easiest to understand, because otherwise it requires engagement with care, but an inaccessible injection. But setting that aside, what they have determined with their PK modeling is that you can start lenacapavir 300 milligrams orally, taken once weekly, starting week 26 to week 28 after your last lenacapavir subQ injection. So you were due at week 26, so between 26 and 28, you start taking oral lenacapavir 300 milligrams once a week. And then you resume your injection about 1 week, but probably plus or minus there, doesn't really matter that much, after your last oral dose, and you can continue this strategy for up to 6 months if needed. I don't know, and any of our pharmacology people can comment on this, like if that really is like after that point your depot's gone and you really can't do it, or if you continue to take it once a week, it would actually be okay, or they just didn't study that. But that's the parameters that they've given. And if it's more than 28 days from any dose, then you need to reload. So if you did this nice strategy of once a week, but then you had a month where you had nothing, then you would have to reload take the 2 with the 2 injections on day 1. But it's hard to know when this would be useful. Like, I do wonder if this is something that we should think about in terms of implementation for people who become incarcerated, and if there's limited access to injectable medications, if somehow getting oral medications to populations in that situation would be useful. You can also cover with other oral PrEP options you could just start taking FTDF or FTAF, but it's just a question of what to do during this tail of exposure if you have ongoing risk of acquisition. So that was one of the things they presented. The other question, one of the other questions they talked about was what to do if lenacapavir, if you start a rifampin. And so thinking about this as being very common in areas with high levels of TB prevalence. So basically what you do is you repeat the whole loading dose schedule starting on the day that you start the rifampin. So and they said repeatedly that the product insert is actually hard to understand for this point. And so there was at one point where they were going back and forth, and then the moderator was like, okay, so let's say you're starting both Len for PrEP and TB treatment. The way to do that is to do your first load, day 1 and 2 of lenacapavir. Then you start your rifampin and you do another load, day 3 and 4 of your lenacapavir, and then you're okay. You can just continue with maintenance dosing. So that is one way. If, let's say, you're in the middle of your window and you start rifampin, then you reload when you restart. So you do the 2 injections, the 2 pills, day 1 and 2. And if you're at your regular injection time, then you reload as you do a reload dose, not just your regular redose, again, right within that window of your rifampin dosing. So does that make sense to everybody? They went over this 3 or 4 times because apparently it's not that clear. And there were lots of promises that the WHO and other guidance would be very clear about this. But that is my best understanding. And they did actually say it would be 4 days long. And if you were starting them essentially concurrently, start the Len first. You always have to start the Len first. And then with the initiation of rifampin, you restart the Len. Okay, I'll just pause there. Any questions about that? And then their next question was, what about with a more moderate inducer, so rifabutin? So for rifabutin, you just do 1 additional injection of lenacapavir. So when you start your rifabutin, you do an additional lenacapavir injection on that day, but you only need to do 1 of the syringes, just the 463.5 dose. And then you should be protected and maintain that curve nicely above where it should be. Then what about with our phosphodiesterase inhibitors? So no restrictions, but similar to protease inhibitors, they suggest that you start with the lowest dose possible and then up titrate as needed to effect, but with the knowledge that you are at higher risk of having adverse effects because you will likely have higher exposure. So I've always, with the protease inhibitor question, sold this as a like a cost saving intervention where you can, if you can split your pills and do better with the lower dose, then you can still get as many pills, but you can use them twice as much. So essentially a similar guidance to that. And then finally for statins, so you only need to adjust for simvastatin and lovastatin. And just in case those sound unfamiliar, so simvastatin is Zocor and lovastatin is Mevacor. I think most of us, I don't know, I'll speak for myself. I mostly use Rasuva and Atorva as the ones that have good efficacy and good interaction profiles with our other medications. But occasionally there are people who, for the insurance preference, are on ones we are less familiar with. So just keep in mind that there is this interaction with lenacapavir, and the guidance here is to just start at a lower dose, quote unquote, and titrate to effect, meaning lipid at goal, and monitor for side effects here, primarily being concerned about myopathies. So what to do for len scenarios here? So the summary of this is missed injection, weekly oral lenacapavir until you're able to resume. Rifampin, you do essentially a reload at the time of starting rifampin. And again, very specific guidance, hopefully in places other than the package insert, which apparently is quite confusing. Rifabutin, you need just one supplemental injection of lenacapavir to get you above where you need to be. For statins, dose adjustments only for simvastatin and lovastatin, otherwise known as Zocor and Mevacor, and phosphodiesterase inhibitors, sildenafil, tadalafil, vardenafil, all of our friends. Safe, but start low and titrate to effect. So I'll just pause there in case anybody has any. Joyce.
Yeah, hi. Thank you so much, Eileen. Colleagues have brought up a concern about fentanyl and lenacapavir. Was that discussed at all? Or no? I mean, it looks like I saw something from Gilead saying it's not anticipated to increase concentrations, but then other references say concern for increased levels of fentanyl. You may want to lower the dose. And just, in the setting of using lenacapavir for PrEP in places where fentanyl is ubiquitous in the, in the drug supply, that has been brought up as a concern.
It's a really interesting question. That was not part of the scope of this presentation at all, but I think also it's like, we used to think more about this like with like lopinavir, ritonavir, and other PIs with like anesthesia for like colonoscopies and things like that when they used a variety of agents, some of which could have more sedative type effects. So that's a really interesting question, and theoretically could be studied in a somewhat controlled setting if there were people on len prep who were having procedures.
Right.
Again, not the exact same scenario, but I'm not aware of that. And I think, but I think it would also be a really good question in terms of a cohort look. Like if you have a cohort where there's concurrent injection drug use and you look at rates of overdose or use of naloxone in individuals who are on len prep, I think that would be really interesting. I don't know. Ethel, do you have any, sorry, you may be unable to speak, but or anybody with any other knowledge about that specific issue with len?
I don't have knowledge about that specific issue, but I think it's a great idea for a small project to look at fentanyl levels in people receiving conscious sedation who are on len prep. So I think with a lot of these things, like the drug interactions are just modeled and projected and predicted rather than people actually doing drug-drug interaction studies where they observe. And there is this kind of wild card of some of the metabolic impacts being a little diluted by the fact that absorption matters so much more than the usual things that matter, like metabolic clearance in terms of determining drug exposures. So I think it should be looked at, but I don't have any knowledge other than that.
Okay, thank you.
Great, thank you for bringing that up. It's a really interesting question. Okay, great. So the next thing I was just going to briefly mention is because this is like a very frequent topic in this conference specifically, is looking at cabrylpivirine in people. So the sort of supposed focus of this presentation was looking at people who are non-suppressed in a cohort setting who are receiving cabrylpivirine. So in the OPERA cohort of 150,000 people with HIV in the United States, about 14% of the US population who has HIV, they analyzed all people receiving cabrylpivirine between January of 2021 and December of 2023. And this was about 3,300 people. 87% of them had the most proximal viral load was less than 50 copies, so that was 2,800. 11% had a viral load greater than 50 copies per mil, so outside of the sort of recommended suppressed viremia at switch, and 2% had a missing viral load, which is 78 individuals. And sorry, I started to write something and then I changed how I was going to write it. So I will just note here that before we get excited about this providing all this data about non-suppressed people, 60% of those who were, quotes, non-suppressed had a viral load of less than 200 copies per mil. So that means there were only 146 people who had a viral load even greater than 200 copies, and they didn't further stratify it by like greater than 1,000. So some of these people may have just had low-level viremia as opposed to being true treatment failures. And so among initiators with more than one viral load at follow-up, if you had a viral load less than 50 copies at your last follow-up, that was 82%. And any viral load less than 50 copies, then 88%. So overall, there wasn't a substantial difference between those who were suppressed and non-suppressed. And here they looked at confirmed virologic failure. So that means more than two or more consecutive viral loads greater than 200 copies per mil, or one viral load greater than 200 copies per mil and discontinuation of the regimen. And they found about this, extremely consistent rate of 1% failure in this group for those on cabrylpivirine. So although there is a substantial number of people with detectable viremia at the time of switch, there was not a higher rate of confirmed virologic failure. So as we've talked about many times, about 1% of people who start cabrylpivirine will develop detectable viremia. And here looking at the individuals who have had detectable viremia at switch, that there are about, again, we see the same rate of confirmed virologic failure. So that was just one little note there. I did not see a substantial advance in our understanding of how to use this particular therapeutic in people who are truly failing therapy. And there's the plug for the open trial that's enrolling that is supposed to actually look at that question. So people who are unable to achieve suppression on oral regimens who switch to cabrylpivirine. And then our next, the next thing we'll look at, and we're going to switch gears a little bit, unless anybody have any thoughts or questions on that. So just a little bit more data, but nothing that I thought really changed what we understand. So also presented at this was the weight management results from the DO-IT trial. This is ACTG 5391, which did enroll here. So it was a multi-center open label randomized superiority trial. So taking adults who are receiving an INSTI, either bictegravir, dolutegravir, or raltegravir, plus TAF FTC for greater than or equal to 48 weeks with stable HIV viral suppression and a BMI greater than 30 kilograms per meter squared. And they had pre-specified enrollment targets to enroll greater than 50% female sex at birth and greater than 50% Black race were enrolled into this trial. And then you were randomized to either switch to doravirine, TAF plus TAF FTC, 47 people in that arm, doravirine plus TDF FTC, 49 people in that arm, or continue on your INSTI plus TAF FTC regimen. I will just briefly mention that the initial plan for this trial was to enroll people who had gained weight on an INSTI plus FTAF regimen, but that was just adjusted to enroll anyone who was on the regimen, and the reason for the adjustment was for slow enrollment. And so this was one of those situations where I think when the trial was being developed, everyone was like, I've got tons of people who've gained weight. But then the specified criteria, which I think was like 10% of body weight or something during the period on the regimen, it was just not possible to enroll enough people. So be that as it may, this was not specifically looking at people who had INSTI-associated weight gain. It was looking at people who were overweight and whether changing them off their regimen, and I shouldn't say INSTI. They were not looking at people specifically who had an ART regimen associated weight gain, here INSTI plus TAF, because I think we have now evolved to think that TAF is potentially also an actor in this process, but just anybody who met criteria for being overweight. So the primary endpoint was weight change at week 48 after the change or stay in regimen, and the secondary endpoints were virologic efficacy and safety, just to confirm that whatever we were looking at was working. So here is the overall characteristics of the group. So the total N was 145. They achieved their 49% female representation, 53% Black race. The median age was 49 years. The median BMI was just about 35. The median waist circumference in centimeters was 111. And how many of them had greater than 10% weight gain in the first 1 to 3 years of INSTI-based ART was 65%. So just more than half of the people actually appeared to have what looked like regimen-associated weight gain as we would have defined it recently. Median CD4 counts were high at 688, and median time on the current INSTI plus TAF FTC regimen was 3.4 years. In terms of which INSTIs they were on, one person was on raltegravir. The 86% or 1% was on raltegravir, which I think is 2 people or 1.5 people. They're probably 2. 86% of the people were on bictegravir and 13% on dolutegravir as their baseline INSTI. And so what did they show? So if you changed to doravirine plus TAF, your weight didn't really change. If you changed to doravirine plus TDF, it looked like your weight changed a little bit. If you stayed on your INSTI plus TAF, it looked like your weight also went down a little bit. So overall, the point estimates for all 3 regimens was weight loss. And there was no statistical difference in the amount of weight loss regardless of the regimen. And specifically, the substitution of doravirine for INSTI did not look like it had a meaningful impact. Now, when they compared the arms, so that's just in the like looking at each arm and what happened independently. So now when you compare them, so if you go to doravirine TAF versus continuing on your INSTI TAF, it, again, wide confidence interval crosses the midline. There's no clear result here. And if you went to doravirine TDF versus INSTI TAF, again, the point estimate looks slightly better, but the p-value is nowhere near significant and the confidence interval is very wide. So the overall bottom line of this result, of this trial, was that in this trial of individuals with BMI greater than 30, changing from an INSTI plus TAF regimen to a doravirine-based regimen with either TAF or with TDF did not lead to significant weight loss at week 48. So I'll just pause there because I think that's disappointing as a result. I will say, I do think that these groups are very small for looking at weight changes. And I think a lot of things go into weight changes. One of my patients was screened for enrollment in this trial, and she has had dramatic shifts in her weight that are directly correlated to how much ice cream and potato chips she eats, which are directly correlated to how much stress she has in her life around her sons. And she would say that too. So she has had very wide swings in her weight over the last 8 years that I've been caring for her, totally independent of her regimen. So when I think of her as potentially being one of these 45 people, it just feels like it's too small of a sample size. But I don't know if other people share that type of instinct about it.
I guess, I mean, I'm not too surprised by these results. I mean, the only drug in the mix that I view as affecting weight is TDF.
Right.
The rest being, I think, neutral. And so, you know, when you switch from TAF to TDF, we have seen some weight loss in several studies, maybe this one, but Otherwise, I wouldn't expect a weight loss with the switch to doravirine.
Yeah.
So I'm not really surprised, but I agree with you. The sample sizes are small, and it's too bad it wasn't a bigger study.
Yeah, and I do wonder a little bit then, and to your point, Joel, I think like the strongest data for TDF and weight loss being in the combination with efavirenz. So like if you really wanted to have a weight loss, I think that would be your combination.
Yeah, if you really want to experience toxicity that results in weight loss, that would be the way to go. Double toxicity.
Right, exactly. Right, to enhance the toxicity towards the weight loss goal. So I think, yeah, and I guess the question of just of whether or not there is some effect that it occurs in some subset of people. And I don't think this study would answer that question. So if you look at very large studies like the ADVANCE trial, where there's a lot of people, there does appear to be a substantial difference in how much weight you gain on these different regimens. And that could just be synergistic toxicity of efavirenz plus TDF leading to less weight gain. It could be that there's subpopulations who are more predisposed to that mechanism or to other things we don't fully understand. The one other thing I was going to mention about weight change, so this is actually not from IAS, but from CID recently, is the DEFINE study. So this was another attempt to look at regimen change, but a different twist on it. So 48-week prospective randomized open label trial enrolled adults with suppressed HIV who were on INSTI plus TAF XTC, so emtricitabine or 3-TC, for more than 6 months. They had to have a BMI that was normal, but not high. And they also enrolled people who had a greater than 10% increase in body weight in the 36 months prior to screening on their INSTI plus FTAF regimen. So they were actually enrolling people who were on a weight gain trajectory. They were randomized 1-to-1 to continue their INSTI plus FTAF or to change to darunavir-CoV FTAF, so a different type of toxicity. And at 24 weeks, there was a delayed switch where everybody rolled over into darunavir-CoV FTAF. And so again, small numbers, 53 people randomized to the darunavir-CoV FTAF, of whom 49 completed the study to week 24, and 50 assigned to continue their INSTI plus FTAF, 46 of whom completed to week 24. And so I highlight that, so this is their summary slide / graphical abstract. And like if you look at just in the purple box, weight gain with an INSTI-based ARV regimen was not quickly reversed after switching to a PI-based ARV regimen. And then they have in bold, there was a trend towards weight loss at 48 weeks after switching. While weight change remains multifactorial, medication management may be a potential method of combating ARV-related weight gain. So I actually don't necessarily think the results support that. But so here, if you follow the green line, that's the people who are on INSTI plus TAF FTC. This is the least squared mean % change in baseline weight, which looks like it's kind of going down from week 4 to week 24. These were people who had gained weight in the 36 months prior, but this is the up to week 24, just continuing. And then at week 24, remember, everybody goes over to the darunavir-CoV. And if you look in the darunavir-CoV arm, like if anything, in that first time, it looks like the change from baseline is positive. And then the slope actually between week 24 and week 48 looks to me more like the slope from week 4 to week 24 in the INSTI group. They did look at key populations, including females, people with a BMI over 30 kilograms at baseline, kilograms per meter squared at baseline, Black and African American in race, and then specifically within females. So I personally would not take this to suggest that 48 weeks on darunavir-CoV is going to lead to weight loss, but which is part of the reason why I brought it up, because I think the summary statement seems a little bit more positive than I would feel about this result. And then the last thing I just wanted to highlight about weight issues. I see that we're almost at time. So this is an analysis from the TRIO cohort, which is like a large database cohort looking at predictors of weight change in 10,000 individuals. And specifically, they're looking at predictors of weight gain of greater than 10% with a shift to a higher BMI category. So this is not just a little bit of weight gain that's annoying, but like, you know, it's categorizing you at a higher BMI that could have potential health consequences. And so they put a lot of variables in the model, and looking here as The ones that are on the right side of this dotted line in the middle here are more likely to have a gain of greater than or equal to 10%. So if your baseline CD4 is less than 200, you're going to gain more weight. Not surprising. Advanced disease, AIDS is a great diet, but taking antiretroviral therapy will reverse that. And then the other two things that fall out are female sex and Black race. So consistent with things that have been observed elsewhere, where there does seem to be some patient factors that may be associated with an increased risk of weight gain. And then here, they're looking at all these different combinations of TAF, TDF, and switches and all those sorts of things, and they see no real impact of any of those medication-related features in the TAF or TDF compartment to weight change. And the interpretation of this study by the authors was that patient factors are more important than specific drugs in determining your risk of weight gain. And I would just say patient factors plus whether or not you've had advanced disease and are starting ART are really the drivers that seem to be the most impactful for weight change. So just to summarize those things, as we're essentially at the top of the hour, I think the data on weight was, there is not positive data from the doravirine F-TAF, doravirine F-TDF switch trial. So we did not see substantial weight loss in those groups, which is unfortunate, but not totally shocking. There's this publication more recently about Drunivir-Cobi as a strategy for weight modification. They interpret a trend in the later stages of that trial. I don't think the data are very convincing that would provide any change in weight. And then in this large cohort analysis, it seems like baseline patient factors are really actually primarily drivers of the risk of greater than 10% weight gain. In the DHHS guidelines that we just had a release of updates in September, there is now a weight gain section, and I'll just say that the recommendations there are that it is like an A-level recommendation not to change specifically for weight, and that the primary drivers of choice should be virologic efficacy. I think that should be caveated that if a patient is unlikely to continue their medication because they believe that there's an adverse effect from it, then it's certainly fine to consider equally efficacious alternative options, but not like as a physician saying, I want to get your weight down, so I'm going to switch you, would be how I would sort of parse that recommendation. So anybody thoughts or questions?
Thank you. I think this is just, such a difficult, I guess, topic for our patients, and something that, it definitely feels like, and we have seen that weight is increasing with INSTIs and/or TAF, but what to do about it with patients is not clear. So
Yeah. Yeah, I mean, I think GLP-1s for all.
Exactly.
Yeah, and I think the only question there is that there's limited data specifically in HIV, and as like one of the centers that has produced so much data from like Greg Kirk and Damani and others on frailty and the considerations around muscle mass loss with GLP-1s, like I do think there's some specific considerations there that we should be thinking about. Although the initial data, it performs the same way, it has the same magical effects on fatty liver and other outcomes. So certainly probably will be part of what we use.
Yeah. Thank you.
Well, thanks so much, everybody. Please send along any cases that you want discussed for next week, and have a great weekend.